Well, thank you for having me here. What I'm going to do on this presentation is review actually how we do this and the discoveries we made between low lean body mass and nutritional status and chemotherapy toxicity and outcomes. Work that my major collaborator did with her graduate student Lisa Martin on the criteria of what is significant in terms of weight loss in cancer patients, and some new stuff that we're doing with skeletal muscle density. So what we have done is validated techniques that were developed for normal patients, general medical patients, that use CT scans to determine lean body mass. And this was work done at the University of Columbia, and we validated it in cancer patients, and using a standard CT scan, you can predict very accurately the amount of fat mass with an R squared of 0.92 and the lean body mass with 0.855. And these are all done with standard CT scans that are done in the routine course of clinical care. What we ideally use is L3, but in actual fact, anything around L3, L4 is sufficient. One thing that we didn't focus on much in the beginning 4 to 6 years ago that we now are becoming increasingly interested in is something called skeletal muscle density, which is below 30 to is muscle, from 30 and up. From 30 to minus 30 is sort of a gray zone. And what that means is this is what we consider bad muscle, in that there is a lot of fat infiltrating the muscle, and the X-ray density is 18.5 Hounsfield units. Hounsfield was the guy who invented the CAT scanner. They named the X-ray density of any tissue after him. And this is considered bad muscle. This is actually considered good muscle. And basically, it's basically marbling. So the more fat that is in the muscle, the worse it is. These are some slides from a long time ago, and basically it summarized my reaction. As a medical oncologist, I always look at the things that aren't supposed to be there, and I've always focused on the things, the lumps in the liver, the swollen lymph nodes. I never focused actually on the things that were supposed to be there that were actually disappearing. So this is the software that we use that produce those nice R-squared values. And the red is the muscle that is colored. And this is essentially the normal amount of muscle. This one is somebody who is profoundly sarcopenic. And as the title said, I had eyes, but I did not see. As medical oncologists, we don't ever look at what's supposed to be there that is actually disappearing. And problematically for us as medical oncologists, these two people have the same body surface area and the same BMI, and they will get the exact same dose of chemotherapy, whether you're doing body surface area dosing or flat dosing of the new chemotherapy drugs. And from what our research has shown, they will have essentially completely different outcomes given the same dose of drug. And this is another example of it. These people are all obese. This person, you actually can wonder how their abdominal contents are actually even being held in their abdomen. And this person is normal. But again, the same BMI and undoubtedly the same body surface area. So standard doses would be given to all three of these people. This is even more interesting. Those other slides that I showed you were in metastatic cancer patients, which everybody feels are cachectic, have significant issues with weight loss, muscle loss. These are adjuvant breast cancer patients. So these are all women with early stage breast cancer that had their breast cancer removed, that were felt to be free of disease. This is, I believe, becoming more of a problem over here. It is definitely a problem in North America, especially in the United States, but also in Canada. Historically, we thought the standard body surface area was 1.72. As you can see, it's moving up. But at the median body surface area in these women, their lean body mass went from 35 kilos all the way to 50. And that was at the same body surface area. So every one of those women would have gotten the same dose of cytotoxic chemo. And what we also showed was that lean body mass accounted for 30% of the clearance of epirubicin, except it varied 200%. So the first part of our research is there is a lot of variation in the lean body mass of cancer patients, even in early stage cancer patients that appear to actually be cured and you wouldn't think would have issues with low lean body mass. Having been involved in this work from the beginning, I am no longer certain whatsoever that standard cute little anthropomorphic formulas that take into account height, weight, and age do anything in terms of predicting actually what the lean body mass is. And as I will get to later, it's made me think a lot about what is a worrisome amount of weight loss in a cancer patient. This was the first study that we actually did looking at the toxicities of chemo as it relates to body composition. I had actually done a study of 104 colon cancer patients treated with the standard colon cancer regimen of 5-FU leucovorin given by the Mayo regimen. And it was a pharmacogenetic study, and we had meticulously collected all the toxicity data by research nurses in real time. So this wasn't a chart review going back and going, oh, is this grade 2 mucositis or whatever. This was immaculately collected toxicity data. And out of the 104 patients, 62 of them had CT scans within 30 days of starting treatment. And as is carved in stone in medical oncology, and given the audience, don't take this the wrong way, women always get sicker with 5-FU chemotherapy than do men. And we found that, again, 67% of the women and 56% of the men had toxicities. Their body composition was all over the place. When we looked at actually the absolute dose of 5-FU that they received per kilo of lean soft tissue, we found that the patients who had toxicity had on average a higher dose of 5-FU. And we found that body surface area, because that's how it was dosed, was not predictive whatsoever of the toxicities. The other thing, which the paper talks about as well, is we found that there was a cut point, and that cut point was 20 milligrams of 5-FU per kilo of lean soft tissue. When you looked at the men and women, and because these were colon cancer patients, there were predominantly more men. Only 2 men went over 20 milligrams per kilogram. One of the 2 men became sick. 13 women went over 20 milligrams per kilogram, and 12 of the 13 became sick. And there are many people that looking at this now think that possibly the lean body mass is the explanation for why women are more likely to get sick than men with 5-FU-based chemo. In fact, Etienne in France is actually looking at dosing capecitabine based on lean body mass, based on this, and more so this. When Carla and I did that first paper, I told Carla this was very interesting, but this could have been just a one-off and never to be repeated. We also did a pharmacogenetic study of capecitabine, also of 104 patients, also meticulously collected. We had 55 patients that were all female that had CT scans. 1/4 of them were what we called sarcopenic, so more than 2 standard deviations, less than what would be expected for their gender and age. And we found that they had much more toxicity than the non-sarcopenics. This was 50% versus 19.5. This was with the standard doses used in breast cancer, not in GI cancer, and I will get to that in a minute. Breast cancer doctors have found that the standard doses used in GI cancers do not work in breast cancer. GI cancer docs in North America use 1250. Breast cancer docs have decided that they can only use 1,000. So being sarcopenic was associated with a 4-fold increased risk of developing toxicity. Tragically so, they also didn't do as well. The hazard ratio in terms of time to tumor progression was 2.6 if you were sarcopenic. I thought this was a potential gold mine in one way. As I told you, GI cancer docs use 1 dose, breast cancer docs use another dose. There are many debates in medical oncology, who is right, who is wrong, whose patients are wimping out, which patients are not wimping out. I didn't think it was actually a matter of wimping out and one group being right or wrong. So we looked at adjuvant colon cancer patients treated with capecitabine as a single agent, and because these were adjuvant colon cancer patients, they all received the maximum dose, the curative dose, 1,250 milligrams per meter squared. When we looked at the total capecitabine dose per the skeletal muscle index, we found that the women were getting about 20% more than the men. And the dose, relatively speaking, between men and women was completely different. After 3 cycles, though, after the medical oncologist had adjusted the dose to each patient's tolerance, both men and women, numerically they were almost the same, and statistically speaking, you could not prove that they were actually different. So lean body mass, I think, explains the difference in dosing between breast cancer patients with respect to capecitabine versus GI cancers. And interestingly, most of my profession subspecialty has been fixated, what is it about breast cancer versus colon cancer that leads to the different dosing? It's not the cancer that's doing it, it's who gets the cancer that's doing it. Colon cancer is predominantly a male cancer, about 65% versus 35%. Breast cancer is even more to the extreme. In North America, it's 96% female and 4% male. So it's not the cancer that leads to the different dosing, it's the differences in who gets the cancer and their lean body mass. Sammy Antoine, who's in charge of nutrition at the Institut Gustave Roussy, brought over about 80 CT scans of patients treated at the Institut Gustave Roussy and in the pivotal study of sorafenib for renal cell cancer. And the reason that he brought them over is if you read in the fine print of the study, the renal cell cancer patients treated with sorafenib who actually responded to sorafenib lost weight, which goes against everything that a medical oncologist wants to believe, that if you actually treat somebody with cancer and they respond, they will gain weight. But in this study, the people who got the treatment, who actually ended up responding, actually ended up losing weight. And we also looked at how they responded to the treatment in terms of toxicity in relationships to lean body mass. And you can think of this, in the way I think of this, as the body mass index is the size of the container or barrel. This is the skeletal muscle index across the bottom, which is how much of the barrel or container is filled with muscle. If you have renal cell cancer patients who are very big and very muscular, only about 1 out of 16 of them got sick. On the other hand, if they were very small and not very muscular, almost 80% of them got sick in terms of toxicity. So lean body mass doesn't seem to be just confined to standard cytotoxic drugs in predicting toxicity. It actually seems to be also involved with the targeted therapies. And not only is lean body mass and muscle related to the toxicities, what we discovered in the case of sorafenib was muscle was manifesting a toxicity itself. Yes, they lost weight. So these are the sorafenib-treated patients, and these are the placebo-treated patients. What they really lost, this is at 6 months and 12 months. What we discovered is they lost weight, but they really were losing a lot of muscle and eventually also a lot of fat. And why is that? Well, because muscle is like bone in a way. It is continuously growing, adapting, and adjusting to its exertional load. And it turns over at about 1 to 2% per day. And it's regulated by essential amino acids, leucine, isoleucine, and exercise. And what regulates and summates all of this is a protein that is well known in medical oncology called mTOR. And this is the internal wiring diagram of the growth, size, regulatory circuitry of muscle. And this is mTOR right here in the bottom of it all. There are growth factors such as insulin-like growth factor, insulin, VEGF, and everything else up here. And this was the problem with respect to sorafenib. Sorafenib was originally designed to be a RAF kinase inhibitor. And as far as we can figure out, as far as muscle is concerned, it is a RAF kinase inhibitor. And we think that is why sorafenib causes muscles to shrink. It also explains some things that Bayer actually saw and observed, which is some centers had no issues or concerns with fatigue and sorafenib. Other centers were actually plagued with it. What those centers did that weren't bothered by it was they had very smart nurses who came to the realization that if patients were exercising before they started sorafenib and exercised a lot while on sorafenib, they never got as tired. And this diagram explains it as well. If sorafenib is blocking this and blocking the growth factors out here, then the external signals to muscle to grow and to maintain its size are lost. But muscle contraction, exercise leading to hypoxia, lowering energy, lowering ATP, all of that acts down here. So by exercising, these people were actually able to bypass the blockade of sorafenib up here and maintain their muscle size. And this is an article that Carla did recently that summarizes all of the different drugs and regimens where lean body mass has been shown to be increased in sarcopenic patients. So the take-home sort of message is that there's tremendous variation in lean body mass in cancer patients, and both classical cytotoxic chemotherapy and the targeted therapies seem to be predicted by that. And not only that, some of the targeted therapies actually target the muscle in terms of toxicity, and I think play a major role in the fatigue, particularly in sunitinib, sorafenib, and everolimus. When Sammy went back to the Institut Gustave Roussy, he looked at sunitinib, everolimus, and sorafenib and discovered they all caused muscle wasting, and they all caused it at the same rate, which fit with my own little theory, which came from this. It was kind of ironic. Vicky Baracos had said to me, okay, clinical pharmacologist, why is this drug, which is treating the cancer, making the muscle shrink? And I unfortunately stumbled across this diagram. One of the best and most interesting papers that has come out of our group has been to answer the question, how much weight loss is significant and or concerning when the entire world, unfortunately, is becoming fat. Historically, 5%, 10% weight loss has been considered significant. Is that still true when many North Americans, particularly the United States, true Americans and Canadians, are becoming fat, and a lot of Western Europeans are? So Vicky and Lisa gathered up data sets, two from Canada, Montreal and Ottawa, set from Ken Fearon, actually sets from Norway and from Southern Europe and Greece. And it ended up being 8,160, and they validated that in 2,963. And the results were interesting. The amount of weight loss that is significant varies by BMI. And it predicts their survival. If you are underweight and you lose up to 2.5% of your body weight, this is your survival median. On the other hand, if you're obese and then some, it's 21.5. What this also shows is that significant weight loss, even in somebody who's obese, is not a good thing in terms of their long-term survival. I just gave a talk at ESMO with Nutricia and Celgene and Shire, focusing on pancreatic cancer, and I treat pancreatic cancer during my day job. And I am no longer thinking that it is so great that my 230-pound previous patients come in and see me at 180 pounds, and I no longer think that that is such a great thing. If I was doing general internal medicine and I was worried about them getting diabetes, cancer, or anything else, that would be great. Based on this data and some of my recent pancreatic cancer patients and thinking about this data, I'm actually thinking that these people who've lost 30 or 40 pounds and now have a normal BMI and normal weight are actually in rather dire straits. And this is it broken down by various different disease types. And as you can see, the more the weight loss and the weight loss categories, the poorer the overall survival. The challenge, though, is even with your new guidelines, which were just released about 2 to 3 months ago from ESPN, they're kind of a one-size-fits-all. And one thing that we're scratching our heads about is it giving everybody the right amounts of various things? Is it giving obese patients maybe too much protein? Is it giving the very cachectic patients too little? And we're actually doing some studies to look at that. We have also, and this is here because I'm here and I may have a very hard time pronouncing most of these names. You will not. You may recognize most of these names. I can only pronounce Bjorgs and Merits. Everybody else, I'm kind of at a loss. This is actually from Norway. It actually were two major Norwegian cooperative group lung cancer studies, and Bjorg analyzed these in terms of lean body mass, and we looked at how lean body mass affected the toxicities of chemotherapy in about 400 Norwegian lung cancer patients. It started off with 658. 200 CTs could not be measured, and it ended up with 424. When that 424 were looked at, whether they were treated with gemcitabine and carboplatin and pemetrexed, carboplatin and vinorelbine, they were indistinguishable from each other. There were no significant differences in performance status, age, etc. We did find, though, to no surprise, that the dose of the non-platinum drug normalized to the average very much predicted the toxicities, and that every 1% increase from the average up or down increased the risk of hematological toxicities by 3%, such that when you increased it, a 20% increase above the average basically doubled your risk, and up to a 40% almost quadrupled it. When we did this in multivariate analysis, numerically, this was highly significant at 0.04 for the non-platinum drug, looking at the whole population. When we looked at it by individual groups, interestingly, the carboplatin dose per kilo of lean body mass was significant also in the gem carbo arm. And from a medical oncology, clinical pharmacology perspective, I think this is because, for whatever reason, that carboplatin synergizes with gemcitabine to a great extent. And not many of the other usual suspects actually were predictive of toxicities, other than age and sex. And to be honest, if I haven't convinced you now, sex may almost be a surrogate for being lean body mass. So, as I said, for every 1% increase in the dose, the toxicity increased by 3%, and for a 1% decrease, it dropped by 3%. Now, I've covered a lot of the cytotoxics and targeted therapies, but if you are keeping up with where medical oncology is going, we have branched into immune therapies to a great extent. I had a very smart young resident working with me for the last 3 to 4 years who actually headed off to Stanford and ended up working actually under Dr. Ron Levy, who invented Rituxan. And we looked at what the effects of body composition, particularly the skeletal muscle density in lymphoma treated with Rituxan. And we've done this actually in 3 lymphomas. I will show you 2 of them here. For follicular lymphoma, which is generally considered to be the less aggressive, indolent, you might die with this, but you are also just as likely to die from something else. We found 148 patients, 79 males, 66 female. This is a prognostic score that is remarkably well validated and widely used. And when we looked at, these are the patients with good muscle in terms of skeletal muscle density, myosteatosis, and these are the patients with the bad muscle, and this is their progression-free survival. So body composition and skeletal muscle density predicted progression-free survival, and almost did even a better job in predicting overall survival. That was the indolent low-grade lymphomas. We then looked at the lethal aggressive ones and found the same thing. These are the low SMDs in terms of progression-free survival, and these are the high. These are the good SMDs, the low SMDs. These are the bad ones. And that is in terms of overall survival. So in terms of passive immunotherapy with a drug such as Rituxan, body composition and skeletal muscle density is also impacting progression-free survival and overall survival there as well. And this we haven't published other than in abstract form, but this was the next logical step, which was what about the active immunotherapies, the checkpoint CTLA-4 inhibitors for melanoma. And we were very much involved in the very earliest trials of ipilimumab for malignant melanoma in metastatic disease. So from between 2009 and 2014, we were treating patients. We found 121, 97 of them had CTs. Not completely surprisingly to me, because I've always thought that melanoma was very much an immunologically driven active cancer, and I think the immune system has a lot to do with cancer cachexia and skeletal muscle density. We found that 70% of these people had very bad skeletal muscle density, which was about the highest we've actually ever measured. Now, with some of these new immune therapies, progression-free survival might not mean as much as it did with standard cytotoxic therapies. There is an intriguing phenomenon in the immune therapies you may not be aware of that's called pseudo progression, which is in actual fact you treat somebody with an immune therapy and their tumor increases in size by 50%. You go, shucks, this isn't working. You stop the treatment. You repeat their CAT scans 3 months later because they're still alive. They feel even better than when you started treatment, and then you repeat the CT scan and you can't find the tumors anymore. And what this pseudo-progression is the immune system is so turned on that it basically rushes into the tumor and causes so much destruction and inflammation in the tumor by killing it that the tumor actually swells. So it's made our lives difficult. So progression-free survival isn't so important anymore maybe in the immune therapies. They actually allow us in clinical trials, if the patient feels better, much better, and the CAT scan looks worse, and the blood work looks better, that we just close our eyes, cross our fingers, and just carry on and repeat the CAT scan in 2 to 3 months. But even in terms of progression-free survival, these are the low SMDs, and these are the high SMDs, and they're doing much better. And this is the real clincher and the really hard to argue with slide. This is overall survival. And none of the bad low SMDs survived eventually. All of the long-term survivors, and every medical oncologist is terrified to use the word cured melanoma patients, were in the good SMD category. And normal SMD predicted a lot of things, and they actually all line up. Many of us who deal with these agents believe, unfortunately, you get nothing for free, even from these things. The patients who get the immune side effects, the hepatitises, the pneumonitis are also the people who actually tend to have their tumor respond. So when you look at this, lo and behold, the patients with normal SMD had a much higher incidence of hepatitis, rashes, than the patients with low SMD. They also had lower markers suggestive of inflammation. So there is something going on, I suspect, hypothesize, speculate, believe, between the immune system and muscles that we can actually measure in the muscles that's actually telling us something about the immune system. And that's it. Any questions?
In regard to toxicity, do you see any difference between sarcopene obese patients and normal weight patients?
Yes.
Yeah.
I wouldn't go so much, in terms of efficacy, very much so. We've done a paper that was in Lancet Oncology that actually showed that sarcopenic obese patients have horrible overall survivals. I would expect that sarcopenic obese patients would also have tremendous issues with toxicities, particularly with cytotoxics. I don't know of, well, we've looked at epirubicin, cyclophosphamide, capecitabine, and 5-FU, and found that every one of them is related to lean body mass, and that the lower it is, the worse their outcomes are, both in terms of efficacy and toxicity. I would actually say that a sarcopenic obese patient would actually be the perfect storm and potentially do the worst of any patient, even compared to a sarcopenic non-obese patient, because our doses are calculated in terms of body surface area. So they would be at a very low lean body mass, which would suggest they would tolerate very low levels of drug. And if you weren't thinking, and the computer just spits out the body surface area and you don't override it, they would get a very large dose of drug. So yes, I would think that most sarcopenic obese patients very much would have issues. And I wrote, when I was a Clin Pharm Fellow at the University of Chicago with my supervisor, Dr. Rattain, a review article on body surface area dosing in cancer chemotherapy. And with each passing year, I think less and less of it. I don't necessarily believe in capping body chemo doses. I occasionally deal with 6'4", 74-year-old Alberta ranchers who are out tossing bales of hay, and their body surface area the computer spits out at 2.5, and I will treat them at 2.5. On the other hand, I have 74-year-old women who come in at 2.4 that are 5'6" tall, and I will cap them. But the horrible thing is we have no good evidence-based guidelines, and you have to be really astute and aware of everything to make those sorts of judgments. And every now and then I deal with people who don't make those sorts of judgments and trying to clean up the mess afterwards.
Thank you, Sawyer, for a wonderful talk. You touched upon protein in the ESPEN guidelines.
Yes.
Ranging from 1.0 per grams per kilo body weight till 1.5. And I was wondering, firstly, do you think it's correctly to assess the needs of protein per kilo body weight?
No, I don't think it is necessarily the correct way at all. From my reading of the ESPEN guidelines, talking to various people and reading, it seems to be very much what we call in North America level 3, level 4 evidence, where people are saying this is what should be done without a whole lot of evidence to back it up. I think more protein is desirable. I'm not certain whether it should be dosed per actual body weight or per lean body mass, depending on what. So yeah, when I gave this talk, actually, a similar talk to this to the Dutch Dietitian Society, we focused on this. So what Carla is doing, and what I'm helping her to work on, is actually she is looking at feeding cancer patients high protein diets and seeing whether or not the protein recommendation makes more sense based on body weight or actual lean body mass. Yeah, she puts it here. So we're randomizing patients to either 1 or 2, and it's being dosed to body weight. And it's a small study, but believe it or not, it's incredibly hard to accrue to, because She wants people who haven't lost a lot of weight, who are within certain BMIs and with certain stages of cancer. And we're looking at lean body mass, energy metabolism, and everything else. And the other thing that's going to come out of this is we're doing DEXA scans on everybody at the beginning and after about 2 months. And by doing that, we're actually kind of doing an experiment by nature sort of thing, in that some of these people are going to get a lot of protein per lean body mass, and other people are going to get a very low amount, and we're actually going to see which makes sense. I think the 1 and 1.5 grams per kilo of actual body weight is on the low end of things. I actually think 2 is preferable.
I know that there are starvation clinics. What do you think of this? Are you aware of this?
And the ketogenic diets and the whole 9 yards on that. The science is interesting in terms of ketogenic diets and calorie restrictions in cancer patients in terms of cytotoxic therapies. On the other hand, the experiments that those studies have been done in are in animals in test tubes. You don't have to worry about the rest of the patient in those settings. I'm not at all in favor of them. You could keep me up here for an hour or two talking about nutrition and body composition, and I could keep going. I did a study that's not in this talk that wasn't even related, I thought, to nutrition, but ended up being related to nutrition. One of my major interests is in metabolomics, which is the study of low-weight chemicals. And there's several ways you can analyze them. How I have focused on it is using 3 NMR spectroscopy. You can also do this with LC-MS, MS. And what we did is we took urine samples from early-stage pancreatic cancer patients. And by early-stage pancreatic cancer patients, the hepatobiliary surgeon had to feel, in looking at the CAT scan, that they could get it out, that it hadn't wrapped around the blood vessels, that there weren't liver mets, that there weren't ugly, awful lymph nodes, that they could get it out. And I had a graduate student who was a general surgery resident who happened to be married to one of the hepatobiliary surgeons. So she gathered up about 40 pancreatic cancer patients that were to be operated on. And we even allowed the ones that couldn't ultimately be operated on, because unfortunately that is life. And the whole goal of this was to discover if there was a metabolic signature in these early-stage pancreatic cancer patients that said that they had pancreatic cancer compared to pancreatitis, pseudocysts of the pancreas, or just normal people. And it was relatively mind-blowing what the signature was. The signature was muscle destruction and muscle wasting. So they had all sorts of breakdown products of muscle catabolism and deranged energy metabolism. What was striking and alarming about that were these were all technically stage 1 and 2 pancreatic cancer patients who were all potentially curable, but as far as their metabolism and their muscles were concerned, they were like on the cachectic path and charging full speed ahead. And that, Lisa's work and everything else has made me think that, sadly to say, if somebody's obese and they come to see me in the cancer clinic, I want them to actually stay roughly obese as I treat them, whether that is simply the obesity paradox, whether that is they are maintaining their energy stores, that they've got backup, I don't know. But deviating from your set body weight that has existed for decades is not a good thing in cancer patients. And it's very interesting data, but when I live in this world for so much of my time, I would be terrified of telling patients, oh, you're getting chemo on Tuesday. I don't want you to really eat anything from Saturday night on. I'm trying to actually get them to keep their weight up, and I'm telling them to eat whey protein like crazy and vitamin D and everything else. So, no, I'm not. If we could figure out what biochemically starvation before chemo did molecularly and could somehow fake that out with a pill without affecting the person's total caloric balance and energy reserves, that would be fantastic. But no, I'm not. Yes.
Okay, thank you so much, Michael.
Yeah.